Our first speaker this morning is Dr. Robert Wortmann. Bob is professor of medicine at Dartmouth Medical School. He received his bachelor's degree at Carleton, his medical degree at University of Kansas. He was an intern and resident and also a fellow in rheumatology at University of Michigan. As many of you know, he was at Oklahoma and now is at Dartmouth. He's been listed in the best doctors in America. He's on the editorial board of the American Journal of Medicine, the Journal of Rheumatology. He's been chair of a safety monitoring board, author over 100 peer review journal articles and over 60 book chapters and reviews. He has his own book on myopathies, and he's going to speak this morning on myopathies 2012.
So I have one disclosure, and we'll admit the initials on these patients that I'll present have been changed to avoid HIPAA violations. So we'll talk about a variety of cases today, and this is a 58-year-old male. He's referred for evaluation of proximal muscle weakness of 4 months duration. He also reports intermittent fevers that did not respond to antibiotics. He has dyspnea, joint pain, Raynaud's, and rash on his hands. His physical examination reveals a rash on his eyelids, bibasilar crackles, swollen and tender MCP and PIP joints, 4 out of 5 proximal muscle motor function, and fissures on his palms. His CPK is 4,000. His EMG shows myopathic changes. This is what his eyelids look like. This is what his hands looks like, and this is mechanic's hands for those of you who've read about it but haven't seen it. And this is what his biopsy looked like. You can see that there are inflammatory cells infiltrating the muscle around the blood vessels, and that at higher power you see the characteristic feature of perifascicular atrophy. The cells at the periphery of the fascicles are smaller than those in the center, and this is characteristic of dermatomyositis. And it's characteristic of dermatomyositis in a patient that has an anti-synthetase antibody. And as you know, we now can measure these. They're commercially available, many of them, and they do help us in our evaluation and tend to tell us what to expect in the future for a patient who has one of these. Of course, if you have anti-SRP, classically you'd have a horrible prognosis. MI2, you'd have dermatomyositis and a very good prognosis. There are exceptions to that, but in general that holds. And the synthetases has a more intermediate prognosis. Now the synthetases are antibodies directed against specific amino acid tRNA synthetases, and JO1 is by far and away the most common. But there are 5 others, PL7, PL12, OJ, EJ, and KS, which are commercially available. And I really encourage you when you're working up patients to send blood to a lab that will measure all 6 and not just restrict yourself to JO1, because patients with these do exist. And more recently has been described antibodies called against HA and ZO. Those aren't commercially available, but they are synthetases. And I'm wondering if somebody were to give an update in 2020 on this topic, it certainly won't be me, but there might be a few more on this list, and that we may have, some people may have antibodies against the other tRNA synthetases that haven't been described. So if you have a synthetase, you can have phenotypically either polymyositis or dermatomyositis. And you know about 80 to 85% of these people will also have interstitial lung disease. These are people that may have fever, frank arthritis, not just arthralgias. They will typically have Raynaud's phenomena. They may have mechanic's hands, and they tend to be difficult to treat. That is, the diagnosis is pretty straightforward. You put them on prednisone and maybe methotrexate or azathioprine, and they get better. But then you say, oh, good, you're getting better, I'm going to taper the medicine, and then they flare. This is very characteristic. There are exceptions, but this tends to be the course for these patients. JO1 is, as I said, the most common. It's an antibody directed at histidyl tRNA synthetase, and this antigen is